Good afternoon, everyone. I will start already with 2 minutes in advance, but I would like to first present myself. I'm Mauro from Lausanne, Switzerland, and I am moderating this clinical vignette on major head trauma, and I have the pleasure to share this clinical presentation with you and with 3 renowned experts, Fabio Taccone from Brussels, Nino Stocchetti from Milano, and David Menon from Cambridge. So we decided together to go on one case which is representative of major head trauma and what these kind of patients may pose us as a clinical dilemma and difficult decisions. So I hope. Right, so the clinical case starts with a conflict between a bike and a car. And of course the guy who is a victim of head trauma is the guy on the bike. And just in terms of epidemiology, I don't know what is going on in other countries, but in Switzerland, we have a lot of bike accidents. Now, Lausanne is a steep town, so a lot of those guys actually have electrical bikes. And electrical bikes, I go daily by bike at the hospital. They are quite crazy because they have speed like 40, 50 kilometers per hour. So that's just the first point. This accident, TBI. So this young man, 18 years old, has a Glasgow Coma scale of 7. Both pupils are reactive and symmetrical. And in terms of extracranial injury, he has vertebral fractures which are stable, aspiration pneumonia, but the gas exchange are known. So this is the admission head CT scan that you see here, which is can be described as abnormal, at least by the presence of intracellular lesions. So I will start with my first question. You have this young fellow, TBI, Glasgow Coma 7, and abnormal CT scan. My first question is, do you want to wake up and perform a clinical examination, or do you want to keep this patient sedated and insert an ICP monitor? So who is going to wake up this patient?
Intubate immediately.
So the patient, good point, is already intubated, so was intubated in the field. So arrived at the hospital intubated, mechanically ventilated, stable in terms of blood pressure, oxygenation. So had CT in the emergency setting. And now who is going to receive this patient in the ICU and wake up, or insert an ICP monitor? Who is for an ICP monitor? Okay, so this is quite reassuring. So we inserted an ICP monitor. So the ICP monitor was inserted in the operating room by the neurosurgeon. At our center, we perform, at least in traumatic brain injury patients in this situation, intraparenchymal ICP. We don't go for intraventricular ICP. Generally, if there is no focal injury or contusion, we insert, the neurosurgeons insert in the right frontal lobe, so non-dominant lobe. And what the neurosurgeon said, yes, Fabio, please.
As it is interactive, I don't know if Nino and David agree on the immediate ICP monitoring or wake-up test. Nino doesn't agree.
He does not, or he does not?
That's why I was just asking whether...
Sorry to interrupt the flow, but I think that the beauty of being together is maybe to encourage discussion. The motor response was 5, I suspect, on the field at the rest of the time, correct?
Yeah.
So it could well be that the patient could obey when he arrived to the hospital. So verbal 1, it doesn't mean anything. I did that to check accurately how the CNS was injured and how much, and how it was evolving is essential. And for sure, no neurosurgeon that I trust will ever put a probe into the brain of the patient unless there are strong reasons. So I think that at the end we could even agree to put an ICP, but without knowing the neurology of the patient, I think that that was unjustified.
Yes, David.
We'd also David first.
So I hesitate to disagree with my learned colleague, but I would not wake this patient up. We know that the patient's got a brain injury, he's got a tight head, his systems are effaced. The risks are that in a young patient who's already got a lot of space in his brain, you may wind up submitting him to a stress of raising cranial pressure without knowing what the ICU is.
Yeah.
Unless there was some kind of a complicating factor, the patient had a seizure at the scene, the GCSF5 combined with the CT would persuade me to try and persuade our neurosurgeons to place a probe so that we knew what the ICU was.
I agree with you on, especially based on the CT scan, because I will show you later on, but this is certainly diagnosis of cerebral edema. So the guy has cerebral edema and has...
Just to add on this point is that you confirmed that before hospital admission there was no confounders like hypotension or hypoxemia?
No hypotension, no hypoxemia. However, the Glasgow is confounded when the patient arrived at the emergency room because he was sedated.
With the drug that is...
So that's why the balance between the Glasgow and the CT scan, what actually convinced us in inserting the ICP was the abnormality of the CT scans in terms of lesions and edema, and the fact that he's a young guy.
In my hospital, we probably put an ICP monitoring for the same reasons that David said, especially when it arrives in the then in the night, so many people cannot wait, and people are very nervous. It's 18-year-old who will not do so much. And I would say, but probably it's not the real life. If someone is there, maybe if you really want to wake up and wait 1 hour, if there's short-acting drug, you can maybe try to do some echo, cerebral ultrasound, see whether it's really, really normal. Maybe you can wait 1 hour to wake up at this, but it's probably not the real life. I think in my hospital we will put for an ICP monitoring quite rapidly because of the, I think, the emotional of a young guy with the risk of a quick ICP without anyone.
I propose to move on because you had a...
I was wondering, like, okay, I think this scan is quite obvious, but there are also scans that don't show that much swelling. Is there not a third option that you admit this patient and that you repeat the scan within a few hours? Would that, do you think, change your debate with the neurosurgeons?
So we have protocolized our treatment. You may be, of course, you may say, okay, you add too many ICP probes. But at our center, abnormal CT scans, Glasgow below 8 in this situation is ICP. And then this is the CT scan within 24 hours. So the CT, the control CT scan, verifying the position of the monitor, which is here. And at 24 hours, this is the CT scan, and it shows again this contusion, and it's a little bit concerning, especially here. So at this point, and this is the other view of the CT scan. Now this is the medical records of these patients, and what you see in red is intracranial pressure, under sedation, propofol and sulfentanyl. And during these first 24 hours, what you see sometimes, and this is the ICP values are sometimes above 20. In the 20s, 2022, there were some values in 23, 24. So the first thing we did was to control and avoid fever by maintaining normothermia, maintaining a PO2 of 100 and PCO2 slight hyperventilation, 35, sedation, and so these allowed to keep the ICP below 20, although sometimes the patient was in between 20 and 25. So I had a few questions for you. Do you regularly monitoring the depth of sedation to avoid over-sedating these patients? Do you think that you should already reduce the temperature to control? Do you think you should reduce more the CO2? Who, based on this CT scan and the ICP above 20, between 20 and 25, would already decompress? So these are questions. Or maybe we should just wake up this guy.
I don't know if you have noticed, the ICP, the opening pressure was 2 millimeters of mercury.
At the beginning, in the operating room.
Sorry to disagree with the rest of the world, but I insist. My colleague, Professor Menon, said he would have insisted with the neurosurgeons to put the ICP. It could well be that the ICP was 30, so I am not arguing. But my question for all of you is, please don't use the total GCS 8 or less. If you intubate the patient and he can't open the eyes, is meaningless. We should rely on the motor component. The motor was 5. My concern is if it was 6, so the patient was obeying commands, how many of you, if it was your brother, would go to the OR and put a probe in the brain? The patient could obey. It should be tested and checked. That was my concern. As for the specific questions that I think are important, I am not an Australian, so an ICP 20-25 is not really a big issue. I think that it requires careful attention and a little bit of basic therapies like the sedation you were using, and if 25 was not really enjoyable, let's start with something minimal like mannitol, rather than resorting to more aggressive therapies. That's my view.
Yeah. Maybe I would add that in the first 24 hours before going to the CT scan, there was a short time window where the patient was stopped in terms of sedation. The colleagues never really got a proper neurological examination because the ICP went above 25. So they didn't wait to do or to perform neurological examination. And this is something you raise is very important. It's always a sort of fight between intensivists and neurosurgeons because the neurosurgeons want to wake up the patient, and the intensivists not only see the ICP values but the ICP curve. So the ICP curve of this guy was a little bit concerning in terms of compliance, and despite, well, we also monitored the brain oxygen. Brain oxygen was in the normal values, but the ICP went above 25. So the decision was taken based on the CT scan to restart sedation, moderate hyperventilation, and control temperature. Yeah.
Until 4 years ago, I would have been very concerned about the value of ICP close to 20, not because I believe that one number is a magic one, but of course because this patient is very close to very non-physiological values. And so as you have only ICP, the patient is sedated, no clinical examination, probably would have been aggressive in terms of mannitol or whatever to reduce the ICP. Then I think it's, well, I say until 4 years ago because you mentioned already other monitoring. Probably, as we already said, the ICP alone is not enough to take all the decision we can. If it was 12, probably my attitude would be different. Within maybe more than 25 or 3 hours, it would be also different, but within 15, 25, basically, it could be tolerated or not. And honestly, I personally cannot answer to the question whether 20 is enough for the patient. So this is why 4 years ago we decided in my department to move for additional monitoring in these patients to understand better how the brain tolerates a certain level of ICP. Probably it's not the common practice everywhere, but it would be very complicated for me to answer to the question.
Quite permissive, and you see this, the red curve is the ICP. So the guy had spikes of ICP between 20 and 25. But we looked at the PbTO2, which was normal, LP ratio normal, and we performed a regular Doppler in this case. So there was an asymmetry in Doppler, but the numbers in terms of Doppler were at this stage relatively okay, but there was an asymmetry. So there was a pulsatility index of 1.2 on one side and 0.9 on the other side, still in normal range. So we said, okay, let's tolerate an ICP in between 20 and 25 because the rest looks okay. And so we got regular osmotherapy.
Before you gave the osmotherapy, the things that we would probably do in Cambridge was to also look at the CPP.
Yeah.
Because we're not going to treat the ICP in isolation. If the CPP was relatively low within the range that we target, if you're using CPP opt, you might try and push the blood pressure up. But in any case, in a young person who could tolerate it, the side effects of hemodynamic augmentation are relatively well tolerated. We would consider pushing the cerebral perfusion pressure up reasonably. Instead of targeting 60, we might target between 70 and 80. I would also look at...
Sorry, David, do you agree on 60-70, 70-80, or you will go for 70-80?
70 to 80, we would certainly try that because occasionally that will magically improve things. So I think the fact that this guy's got a ICP of 20 is telling us two things. If it gets higher, then he's in danger from complications of the raised intracranial pressure, but it's also telling us something about the severity of his disease. So I think we need to try and be careful about it. This is relatively early in the course of illness. It doesn't have a surgical lesion. It's a biomarker of significant importance. So I'd get everything else right. What is the sodium? Even if the sodium is normal, has it dropped from where it was before? That would be a second thing to get. And the temperature we've controlled, we've said.
Yeah. So temperature was kept at 36. You see the CPP was rather in the 70s, 70, 75, so at least above 70.
Yeah, we would probably accept that, yeah.
Right. And I go to the sodium. So sodium was 145, 146.
Not bad.
With regular, osmotherapy. Now the question here, who is for mannitol, who is for hypertonic saline, who is for a mixture of both?
Vote. Vote for mannitol, for hypertonic. I for hypertonic saline.
Other
Let's vote.
Hypertonic saline believers? Okay. Are there mannitol believers? Are there democratics who don't care about both? Okay. So we are also rather hypertonic saline, but of course there is no evidence whatsoever that one is superior to the other. And we even took some time in the last years to come out with the consensus documents that there is no difference, except one important fact, that both are very effective in reducing ICP. Do you agree?
Yeah,
Okay.
one has the disadvantage of also being a diuretic.
Right,
Which is a big disadvantage when you're trying to maintain CPP.
Now be careful about hypertonic saline, because repeating hypertonic saline may increase sodium and also is extra fluid, extra chloride.
So increasing sodium is a good thing, because when you give mannitol, you have no way of monitoring it unless you actually measure osmolality. With sodium, Sodium is the osmolyte, so you just have to measure a blood gas machine. You know what your osmotic load is.
Now, do you go for sodium or measured osmolarity or both? And then what is the maximum you would recommend?
It depends on how bad the intracranial pressure is. So there are patients who wind up with intracranial pressures that are high, and because we don't want to decompress them for other reasons, we may wind up with sodiums in the high 150. But once it gets towards 160, you would actively prevent it from going up.
Okay, 160.
But we have 155.
We have 155 as limit. 155 as tolerance limit.
Yeah, I think that before going to 155, which is totally again all homeostasis, you should probably consider that, as David said, the danger zone is becoming closer to the patient.
Yeah.
So,
So we put the level of CO2 a little bit lower because we were confident in terms of PPTO2, which was normal. And we use an automated temperature control. In this situation of intracranial hypertension, we tend to use these modern devices for temperature control. Okay, this comes to day 4. Now, why we did repeat the CT scan is because we were still concerned about the spikes of ICP, sometimes quite high, 25, 30 you see in red. And so we were a little bit concerned. So we repeated the CT scan, and I was personally quite concerned about the CT scan because I think that there is a worsening. There is some effacement here of the ventricles. And so at the same time, well, let's put these questions aside for a moment. At the same time, we repeated the Doppler. And the Doppler was alarming. Now you see, it's in French, but basically you have a very high pulsatility index of above 1.5, and the patient at this stage has ICP that was repeatedly above 25. And there is another thing that I wanted to show you, is the fact that not only there was this pathological Doppler on the right side, but we also noticed by measuring pupillometry that there was also an asymmetry. And one side was affected and showed pathological numbers. So now the question is, and the patient is now with PCO2 of 30, temperature 35.
Where is located the PPO2 catheter? Is on the right
So
side
it's the same. So you see
on the right
it here. You see it here. So right side. So it's at the same side of the lesion. Now I ask you. Well, yes.
I have
Please.
one more question. The sedation was more or less tripled in the time course.
Yeah.
I mean, the CT was absolutely expected, wasn't it?
Sorry.
In the young guy, was it kind of? You have in this period with the uprising ECPs, if I saw it right, triple of the sedation in the doses. So the development of an edema isn't really.
Well, triple sedation.
No, triple in the doses is going up, right? You have propofol, triple doses. You have sulfentol, double dose. You have midazolam with this triple doses.
Well, the data here shows the cumulative dose over time.
Right.
So it's 4 milligram kilo.
Okay.
4 milligram kilo of propofol, addition of some midazolam, and then sulfentol. Now, at this time, we did not really regularly monitor using EEG or BIS. Nowadays, we started using, because you often see that actually the patients are over-sedated, receive too much sedation, and the numbers of the BIS or sort of BIS monitoring are very low. Now, what would you do here?
Let's vote for craniectomy.
So who is for, based on the actual evidence? Now you can discuss about evidence-based medicine or quoting David Menon, medicine-based evidence, but what would you do? Who is for calling the surgeon?
Mauro, I have a question. Do you have a clear explanation why the right hemisphere is pushing on the other side? So what is happening on this right hemisphere? What is your interpretation?
I think it's due to this lesion to the temporal lobe that is pushing. So, well, I didn't put the comparison between 1 and 4, but it seems that it's something going on here, the temporal lobe pushing, and you see that there is, so the radiologist told us that there was more than 5 millimeter deviation. So
Mauro, two questions. Did this guy have a fracture base of skull? And if,
no.
No fracture base of skull. The second thing is, do you have a microdialysis probe?
Yes.
What's his glucose, brain glucose?
Extremely low.
Okay.
So I was, look here. And that was a bit strange because the LP ratio is not so high, but this guy starting at day 2 has very low glucose values.
So I would think about whether giving him some glucose might make a difference, pushing up his blood glucose a bit, and think about giving him ketamine instead of giving him propofol, because so this guy's probably going to wind up, or he has a strong chance of winding up getting a decompression. The question is whether we can avoid it for the reasons that all of us want to avoid it. And there, one of the things I would think about is whether he has episodes of spreading depression. We don't put in probes to measure it, and I'm not satisfied with surface EEG, he tells us. But a trial of ketamine in someone in whom the brain glucose is low, especially if it's episodically low, is something we found over the last year as being very helpful.
Would you observe in this case also a point oscillation of PBO2 that's been described in CCC?
So I used to think that you'd expect to see long episodic PO2 because repolarization is very oxygen hungry, but the pragmatic answer is we've seen response to ketamine despite burst suppression with propofol, even when the PPO2 isn't low. Or on the other hand, the PPO2 is marginal, we're holding it up using a variety of other methods, maybe slightly high FI2, slightly high CPP. But giving them glucose makes a difference because hypoglycemia predisposes to spreading depression. So we'd get blood glucose up to 180 milligrams, 10 millimoles, no higher than that. And then we would think about giving them ketamine. But all these are temporizing measures to see whether they turn the corner or not. If not, then you need something more definitive.
Well, I'm happy to see that you all were temporizing, because that's what we also did. And especially because we're confident about brain oxygen. But this, I think, in the end, I think this was a little bit overconfidence.
You have also the thing is the pupillometry showing an asymmetry,
yeah.
The Doppler showing an asymmetry. But you have the CT scan, you have some
so the trigger
concordant signs that there is, that must affect, as Nino said, the midline shift. So the brain is in danger now. So of course, this device doesn't tell you which is the
right. But the message is that the trigger here was not the intracranial monitoring, but more the imaging. The Doppler, the CT scan, and sort of also what you could call imaging also, although it's a little bit, it's the pupillometry, showing pathology. So we don't go for deeper temperature. In this case, we considered that barbiturate coma was not a good option, and in the end, it was decompressed. He was decompressed. Now I want just to show you the evolution of glucose after decompressive craniectomy, which I think is quite evident and spectacular, and also look at the pupillometry, because this was very low, below 3, and then it went up after the intervention, which we considered was okay. So everything was stabilized, the ICP went down, brain oxygen still okay. We were quite happy, and then after 2-3 days, this is the LP ratio. And that's where I started thinking, okay, what is going on here? And I wanted to tell you that after day 1 and 2, the ICP went a little bit up in the 15-20. Lactate-to ratio was up. We stopped the sedation, and the patient didn't wake up and started having very subtle movements.
Mauro, can we go back one?
Yeah.
Of course. Okay. Just for the pleasure of trying to understand the numbers. When glucose, extracellular brain glucose, is very low, we are concerned. It's always difficult to interpret. It could be that the cells are using like crazy the glucose available, but it may also well be that we are not providing enough delivery. I think that that was the concern of Professor Menon, so I share the concern. Very low glucose levels are bad. Then we should provide normal delivery. The reason why I want to spend 30 seconds on these values is because when you have over normal values, so you have increasing values exceeding normality, it is not a good thing. It's like to say that I would like to avoid hypotension, then I have normal tension, then I have 400 millimeters of mercury systolic. It's not good. I think that it's worth considering because my experience, I have a little bit of data, is that when you have a decompression, the mismatch between flow and metabolism is induced by our intervention. It's like to create a fistula. So you have an overabundant flow that may explain these supernormal values. So it's much better to have glucose than not to have it. But when you have too much, you should think about it.
And that was parallel with this increasing lactate to pyruvate ratio and the fact that the ICP went again up. Now I don't show the Doppler, but the Doppler showed hyperemia. And then in the end, we did this EEG, and the patient showed non-convulsive seizures, so he was put on anti-epileptic. To make, since we are reaching the end, actually the decompressive craniectomy was fine for the ICP, additional complications in terms of secondary insults, and then there was still some issues with decompression. This was the day 18 brain MRI, showing lesions that are compatible with diffuse axonal injury. And this is the neuropsychological examination at 1 month. So we were at this stage a little bit concerned because of the severe attentional deficits, executive dysfunction, and neglect in a young patient. So neuro rehab, and this is the 6-month brain MRI, which still shows these lesions compatible with diffuse axonal injury, no real improvement. 1 year after, the patient still had problem after the compressive craniectomy, putting the bone, and had necessity for a bone plastic reconstruction. But what I wanted to show is that there is no doubt that in the beginning that this was a severe edema when you compare to what can consider normal in these patients. And then that 1 month or even 6 months is not enough. And there was a good recovery if you consider the score of the neurosurgeon. The patient is doing very well, 18 months. And post-neuro rehab, the comment of the neurohabilitator was the patient has a mild cognitive deficit and is back to school, well integrated into his previous life. So I don't know whether the decompression was helpful or not. Associated with quite a few complications, but this is the end of this story.
Did he improve after the cranioplasty? I'm just wondering whether the hemi-neglect was a consequence of trophine.
I actually did not find the exact neuropsych exam before the bone plastic.
And the comment I would make is that the extent of DAI on an SWI image isn't excessive.
Yeah.
Normally you would see much more. That is compatible with a good recovery. We see this quite frequently. And hopefully TBI will provide us with quite a lot of evidence.
But I think the trajectory of those patients need time. So I don't know if you have additional questions. We are a little bit behind with try 3 minutes.
Do
behind you.
Because I see someone asking for
There's another session.
Okay.
in 2 minutes.
Oh, then we definitely have to leave. Thank you all.